You usually when we talk about orthopedic surgery, there's this underlying expectation of mechanical precision. It's almost like structural engineering,
Oh, absolutely, yeah.
right? I mean, a patient comes in, they've broken their femur, you look at the x-ray, and there's that jagged white line.
Yeah.
It is just undeniably a fracture.
It's very binary.
Exactly.
Yeah.
You point to it, you classify it, you fix it. The pathology is entirely visible.
And it's incredibly comforting for a surgeon to operate in a world where the problem is that tangible. You can physically hold a plate or a screw.
Yeah, you see the reduction right there.
Right. We're trained to appreciate things that can be rigidly categorized.
But then, and this is the painful part, you transition from the operating room to exam revision for the FRCS. Specifically, you arrive at the basic science finale.
Oh, yeah. Statistics, evidence-based medicine, and theater science.
Yeah. And suddenly, that high-definition X-ray machine is just broken. You're no longer looking at clear, jagged white lines.
Not at all.
You're standing in this diagnostic and statistical landscape that feels, honestly, entirely abstract. It's really murky.
It is the absolute definition of diagnostic muddy waters for, well, a huge percentage of candidates. I mean, for someone who spends all day thinking about biomechanics and anatomy,
Yeah.
stepping into statistical distributions or the physics of fluoroscopy, it just feels like trying to read a completely different language.
And that is exactly why we are here today. If you are listening to this deep dive, you are likely preparing for the FRCS Trauma and Orthopedics exam.
And you're probably stressed.
Very stressed. And if you are, like most candidates, you've looked at the syllabus, seen statistics and EBM, felt your eyes completely glaze over, and decided to leave it until the last possible minute.
Or worse, you've convinced yourself you can just skip it entirely.
Right. I'll make up the marks elsewhere. Let me be the first to tell you that is a massive strategic mistake.
An incredibly costly mistake, because despite how intimidating the nomenclature sounds, these are fundamentally free marks.
I love that phrase, free marks.
They truly are. I mean, unlike complex surgical approaches where there are a dozen anatomical variations, statistical rules and theater physics do not change.
They are absolute.
Exactly. This entire section of the curriculum is finite. It can be internalized and completely mastered in a single afternoon.
And these questions appear in every single sitting of the exam.
Without fail.
Yeah.
So leaving them blank or guessing is it's leaving points on the table.
So let's acknowledge your reality right now. We know exactly who you are, and we know you are not sitting at a mahogany desk in a quiet library with 4 different colored highlighters.
No, definitely not.
You are driving home from a long shift.
Uh.
You are on the train. You're unloading the dishwasher or on a treadmill. You cannot physically write anything down.
Which means the burden of structure is entirely on us today. We are going to build the architecture of this knowledge directly in your mind.
Just using auditory repetition and logical synthesis. You won't need a piece of paper because we're going to rely on how concepts connect to one another. So, the strategy today is rigorous but deeply practical. Because you can't take notes. Every essential rule, every exam trap, and every critical discriminator is going to be stated, and then I am going to intentionally synthesize and repeat it.
We call it the twice rule.
Exactly. If you hear a concept twice, that means it is high-yield, tested material. We will also build in mental checkpoints, brief recaps, to consolidate what we've just covered.
Before we move into new territory.
Yeah. And at the end of every topic, I'm going to distill it down to a single, if you only remember one thing, takeaway.
That's perfect. And we are going to start with the monster that scares everyone the most.
Statistical tests.
Statistical tests. The secret here is that you do not need a degree in epidemiology. You just need a decision tree. Almost every single stats question in this exam can be unlocked by answering just 2 sequential questions.
Okay, let's build that tree. Topic 1. Choosing a statistical test. When you're reading a densely worded question stem about, say, a clinical trial comparing 2 different surgical implants, what is the very first question you have to ask yourself?
Question number 1 is the data parametric or is it non-parametric? That is the fundamental fork in the road.
Okay, parametric or non-parametric. We hear those terms constantly, but let's anchor them to what they actually represent clinically. Parametric data.
Right.
This is our continuous data that forms a relatively normal distribution, like the classic bell curve.
Correct. When we say parametric, we mean data that is measured on a continuous sliding scale. The mathematical intervals between every single point are perfectly identical.
Give us some orthopedic examples.
Sure. Height, weight, blood pressure, range of motion in degrees.
Right, because the physical difference between 100 degrees in knee flexion and 101 degrees is the exact same unit as the difference between 50 degrees and 51 degrees.
Exactly. It is continuous, measurable, and normally distributed.
So parametric equals continuous measurable data. Let me say that again for the drivers. Parametric equals continuous measurable data. Now, the other side of that first fork is non-parametric data. And in orthopedics, we actually live and breathe non-parametric data.
We absolutely do, even if we don't realize it. Non-parametric data does not form a beautiful bell curve. In surgical research, this is almost always ordinal data.
Ordinal.
Yeah, ordinal meaning the data is organized into ranked categories. A perfect example is a subjective pain score.
Right, like asking a patient to rate their pain from 1 to 10. That's an ordinal rank.
Exactly.
The patient can tell me that a 7 is worse than a 6, but I cannot mathematically prove that the neurophysiological jump from a 2 to a 3 is the exact same shift as moving from an 8 to a 9.
It's a rank, yeah, not a continuous mathematical unit. And practically every classification system you use in orthopedics is ordinal.
Like what?
The Kellgren-Lawrence grade for osteoarthritis, or the Herring classification for Perthes disease. Grade 3 is worse than grade 2, but it's a category.
Right, so repeating that rule, non-parametric equals ordinal, ranked categories like disease grades. So that's question 1. Is the data parametric continuous range of motion or non-parametric and ordinal disease classification? Once we have that answer, what is question 2?
Question 2 is about the subjects in the study. Are the groups paired or are they independent?
Okay, let's define paired first.
Paired groups mean you are looking at the exact same subjects measured twice. The classic setup is a before and after study.
So same people, 2 time frames.
Yes. You measure a patient's continuous knee range of motion, you perform total knee replacement, and you measure that exact same patient's range of motion 6 months later.
Got it. The 2 data points are intrinsically linked because they belong to the same biological system.
Right, they are paired.
And if they aren't the same patient?
Then they are independent. This means you have 2 completely separate, distinct groups of people.
Like Group A and Group B.
Exactly. Group A receives a novel biologic injection. Group B receives a saline placebo. The individuals in Group A have no biological link to the individuals in Group B.
So they are independent, unpaired groups. Let's cement those 2 keys to unlock the tree. Parametric or non-parametric? Paired or independent?
Now we walk down the branches. Let's start with the parametric branch.
So we have continuous bell curve data here.
Right. Walking the parametric branch. If you have continuous parametric data and you are comparing 2 independent groups, 2 completely separate cohorts of patients, the correct statistical test to use is the unpaired t-test.
Also called the independent t-test.
Yes, either name works.
Let's lock that in. If the exam describes parametric data measured across 2 separate independent groups, you are reaching for the unpaired t-test. Unpaired t-test for 2 independent parametric groups.
Now, what if you have that same continuous parametric data, but the measurements are paired before and after surgery in the exact same group of patients?
Well, logically, that would be the paired t-test.
Exactly, the paired t-test.
That's nice and easy.
It is. But the complexity increases slightly if you have more groups. What if you are comparing continuous parametric data, but you have 3 or more independent groups?
Like Group A, Group B, and Group C.
Yeah. You can no longer use a simple t-test. For 3 or more groups of parametric data, you must use ANOVA analysis of variance.
Let me synthesize that progression for everyone listening. We are on the parametric continuous data branch. If I have 2 independent groups, it's an unpaired t-test. But the moment I add a 3rd group, comparing 3 different surgical approaches, for example, I have to graduate from the t-test and use ANOVA. 3 or more parametric groups equals ANOVA.
Spot on. And there is one final test on the parametric side. What if you aren't comparing groups at all?
What do you mean?
I mean, looking for a straight line mathematical relationship between 2 continuous variables within a single group. Like asking, does a patient's BMI correlate with the duration of surgery?
Well.
For that, you use the Pearson correlation coefficient.
So Pearson is for looking at the correlation between 2 continuous variables.
Got it. So that is the entire parametric branch. Now, we must walk the non-parametric branch, and listener, pay extremely close attention here because we are about to flag a massive, heavily circulated error in one of the popular source quizzes that candidates use to revise. Yeah, we really need to correct the record on this because relying on flawed practice material will actively cost you marks.
But first, let's build the non-parametric branch.
The elegant thing about this decision tree is that the non-parametric tests perfectly mirror the parametric ones. We are simply substituting the names based on the data type.
So instead of continuous data, we are now dealing with ordinal data, categories, and ranks. Let's mirror the tree.
If you have non-parametric data like an ordinal classification system, and you are comparing two independent groups, the correct test is the Mann-Whitney U test.
Let's cement that. Two independent groups, non-parametric ordinal data, the answer is the Mann-Whitney U test. Repeating again, two independent non-parametric groups equals Mann-Whitney U.
Now, if you have non-parametric data, but the measurements are paired, say an ordinal pain score before surgery and then the pain score after surgery in the same patient, the test is the Wilcoxon signed rank test.
Consolidating that rule, paired measurements, non-parametric data, equals the Wilcoxon signed rank test. Paired non-parametric is Wilcoxon.
And finally, if you have non-parametric data across 3 or more independent groups, the correct test is the Kruskal-Wallis test.
3 or more groups, non-parametric data is Kruskal-Wallis. Okay, so we have the architecture built. Now bring in the exam trap. Where does that source quiz go catastrophically wrong?
Okay, so there is a specific practice question out there. It presents a scenario where researchers are comparing the Perthes disease grade, specifically the Herring classification.
Right.
They're comparing it between 2 independent groups of patients, a rural cohort and an urban cohort, and it asks you to identify the correct statistical test.
Okay, let's apply our own decision tree to that exact stem.
Huh.
The Herring classification is a grade based on the height of the lateral pillar of the femoral head. It's A, B, or C. That is a ranked category.
Exactly.
It is ordinal. Therefore, question 1 is answered. The data is non-parametric.
Yes, non-parametric data.
Now for question 2, the stem explicitly says it is comparing rural patients versus urban patients. Those are 2 separate distinct cohorts. So we have 2 independent groups.
2 independent groups.
So if we follow the logic we just established, non-parametric data, 2 independent groups, the mathematically inescapable answer must be the Mann-Whitney U test.
It absolutely must be. But if you look at the answer key for that specific source quiz, it incorrectly claims the answer is the Kruskal-Wallis test.
Wow.
This is categorically false. As we just learned, the Kruskal-Wallis test is strictly reserved for 3 or more groups. You would only use it if you were comparing rural, urban, and suburban cohorts.
But for just 2 groups.
For 2 groups, it is always the Mann-Whitney U test.
This is exactly why rote memorization of question banks is so dangerous. If you just memorize the key, you will fail the real exam when they change the scenario slightly. I want to emphasize this correction heavily for the listeners.
Please do.
The quiz asks for a 2-group ordinal comparison. The quiz says Kruskal-Wallis. The quiz is objectively wrong. Comparing an ordinal classification across 2 independent groups is the Mann-Whitney U test. Learn the logic in the tree. Do not memorize a flawed key. 2 non-parametric groups is Mann-Whitney U.
Well said. Now, before we leave statistical tests entirely, there are 2 distinct outliers that don't neatly fit onto our parametric or non-parametric branches.
But the exam loves them anyway.
Of course they do. We need to define the tests for categorical data and for survival data.
Let's tackle categorical data first, because this isn't continuous and it isn't even ranked.
Right. Categorical or nominal data is purely descriptive buckets, proportions and percentages. For example, how many patients had an anterior approach versus a posterior approach? Or how many patients developed an infection versus no infection?
There is no rank there, no continuous scale.
None. It's just counting heads and buckets. When you are comparing the proportions of categorical data between groups, you use the chi-squared test.
Okay, so if the exam describes a study comparing the percentage of wound infections between 2 different operating theaters, we're dealing with pure proportions, which means we use the chi-squared test. Categorical proportions equals chi-squared.
Exactly. And the final outlier is time to event or survival data.
Now, in orthopedics, we aren't usually talking about patient mortality, right?
Yeah.
We are talking about implant survival.
Right, like how many years does a total hip arthroplasty survive before requiring revision surgery?
You see this constantly in National General Registry reports.
Yeah. Whenever you are analyzing time to event data, you plot it visually using Kaplan-Meier survival curves.
Kaplan-Meier curves.
And if you want to statistically compare 2 different Kaplan-Meier curves, say, comparing the survival of a cemented stem versus an uncemented stem, the mathematical test you use is the log rank test.
Let me make sure that sticks. Implant survival data is visualized with Kaplan-Meier curves,
Yeah.
and we compare those curves using the log rank test. Kaplan-Meier and log rank test for survival data. All right, if you only remember one thing from this entire topic on statistical tests, it is this. 2 questions. Pick your test. Is it parametric or non-parametric? Is it paired or independent? If you have 2 independent parametric groups, reach for the unpaired t-test. If you have 2 independent non-parametric groups, reach for the Mann-Whitney U-test, and never let a flawed practice quiz convince you to use Kruskal-Wallis for only 2 groups, Mann-Whitney U for 2. Let's transition into topic 2, descriptive statistics and study design. We've talked extensively about how to compare data sets. Now we need to discuss how we simply describe the data we've collected and how we design the studies in the first place.
Let's touch briefly on descriptive statistics. I'm assuming a baseline level of mathematical literacy here. You know that the mean is the arithmetic average, and the median is the literal middle value of a sorted data set.
Right. The exam isn't going to ask you to just define those basic terms.
No, what they test is how you handle skewed data.
This is a classic trap. And hospital lengths of stay is a great example of this, isn't it?
It is the perfect example. Most patients stay in the hospital for a very predictable, tight cluster of days after a joint replacement, say 2 to 4 days.
Sure.
But there is always a tiny handful of patients who have catastrophic complications and end up in the ICU for 45 days.
And those outliers stretch the tail of the data way out to the right.
Exactly. That is a right-skewed distribution. And the exam wants you to know how that skew affects the descriptive statistics. Extreme outliers heavily influence the mean.
Right, that 45-day stay drags the mathematical average way up.
Yeah, making it look like the typical patient stays for 7 or 8 days, which just isn't true for the vast majority. But the median, the middle value, barely moves at all. Therefore, in skewed data, the median is a far more accurate representation of the central tendency than the mean.
That is a crucial insight. Let me repeat it. When the data is heavily skewed by outliers, the median is your reliable anchor. Outliers drag the mean, but the median stays anchored. Now, what about the mode?
The mode is simply the most frequently occurring value in the dataset. If more patients stay exactly 3 days than any other number, 3 is the mode. It is the most common observation.
I use a verbal analogy for this to keep it straight. Think of mode as a la mode, the most popular or frequent choice on the menu. Mode is the most frequent.
I like that.
So mean is pulled by outliers, median stays anchored in the middle, and mode is simply the most frequent observation. Now let's elevate this to how we actually design the trials generating this data. Let's talk about the gold standard of evidence-based medicine, the double-blind, placebo-controlled, randomized trial.
The term double-blind is thrown around constantly, but the exam specifically tests your precise understanding of who the blinded parties are.
One party is obvious, right?
The patient.
Yes. The patient cannot know whether they are receiving the active intervention or the placebo, because the placebo effect is a powerful biological reality.
Patient blinding is a given. So who is the second blinded party that makes it a double-blind trial? The trap here is thinking it's just the treating surgeon. The trap is exactly that. The crucial, heavily tested definition of a double-blind trial is that the clinician or researcher who is assessing the outcome must be blinded to the treatment allocation.
Unpack the why behind that.
Yeah.
Why is it so critical that the outcome assessor is completely in the dark?
Because human bias, even subconscious, well-intentioned bias, is incredibly powerful, especially when evaluating subjective outcomes.
Right.
If a surgeon knows that a patient received a shiny, astronomically expensive new implant that the surgeon maybe helped design, they might subconsciously encourage the patient slightly more during a range of motion test.
Yeah.
They might interpret a vague complaint of pain favorably. They might round up the clinical score.
You want the intervention to work,
Yeah.
so they see what they want to see. Observer bias.
Precisely. Observer bias. To completely eliminate that, the person evaluating the treatment effect, the assessor, must have absolutely no idea which group the patient was allocated to.
Let's consolidate that rule twice. In a true double-blind trial, the specific tested definition is that the outcome assessor must be blinded alongside the patient. It protects the data from observer bias. The outcome assessor is blinded. Now let's talk about what happens when you take dozens of these trials and combine them. Let's step into the world of meta-analysis. The exam loves to test your understanding of the 2 primary visual plots used in meta-analysis, forest plots and funnel plots.
Oh, they love these.
Because this is an audio deep dive, we need strong conceptual anchors to keep these straight without looking at a graph. How do we distinguish them?
The best way to learn them is as a functional pair. They exist to do two entirely different complementary jobs. One builds the picture, the other tests the integrity of the picture.
Let's start with the forest plot.
A forest plot is fundamentally a summary tool. It takes the individual results of multiple different trials and aggregates them to give you one grand pooled overall effect size.
My conceptual anchor for this is right in the name. A forest plot gives you the forest view. Instead of getting lost examining the individual trees, the single isolated studies, you step back to see the entire forest.
Yeah.
It is a visual summary of the big picture.
That's exactly how to think about it. It visualizes every study's effect estimate as a square, with horizontal lines representing the confidence intervals. And at the very bottom of the plot, there is a diamond.
The famous diamond.
Yeah, that diamond represents the mathematically pooled, synthesized overall effect of every single study combined. So forest plot equals summary of treatment efficacy.
Got it. Forest plot summarizes the overall pooled effect. Now, what is the job of the funnel plot?
If the forest plot is a summary tool, the funnel plot is an investigative tool. Its primary job is to detect publication bias.
We need to define publication bias carefully because it dictates why the funnel plot even exists.
Imagine you run a small clinical trial testing a new pain medication, and the drug is a total failure. It doesn't work any better than a placebo. When you try to publish that paper, major medical journals are likely to reject it. They are biased toward publishing exciting, statistically significant, positive results.
So those small negative studies just end up quietly shoved into a filing cabinet in a university basement somewhere. They disappear from the scientific record.
Exactly. That is publication bias. The literature becomes artificially inflated with positive results. A funnel plot is designed to expose that.
How does it do that?
It plots the precision, usually the size of a study, against its reported effect. In a perfect, unbiased world, the plot should look like a symmetrical inverted funnel. The massive, highly accurate studies cluster tightly at the top, and the smaller, more variable studies spread out symmetrically at the bottom.
So a small study might show a huge positive effect by random chance, but another small study should logically show a huge negative effect by that same random chance. They should balance each other out at the bottom of the funnel.
That is the exact mathematical principle. But if that funnel plot is distinctly asymmetrical, if there's a massive gap where all the small negative studies should be, it visually proves to the researcher that publication bias is present.
Because those negative studies exist in reality, but they are missing from the published literature.
Exactly.
The analogy I use here is a literal physical funnel like you use to change the oil in a car. You pour all the published literature into the top of this mathematical funnel to see what passes through smoothly, and more importantly, what is missing or structurally asymmetrical at the bottom. It detects what is fundamentally missing.
It is a brilliant investigative check. Forest plot summarizes the pooled effect. Funnel plot detects publication bias.
To cement that pair twice, Forest gives you the summary view of the overall effect. Funnel detects the presence of missing studies and publication bias. Forest summarizes, funnel detects bias. If you only remember one thing from topic 2, it is this. In skewed data, outliers drag the mean, but the median stays anchored. In a double-blind trial, the crucial fact is that the outcome assessor is blinded. And functionally, Forest plots summarize the pooled effect, while funnel plots detect publication bias. Let's pivot directly into topic 3, screening. We've discussed how to gather and evaluate evidence. Now we look at how public health systems apply that evidence to massive populations.
Yeah.
We screen for developmental dysplasia of the hip in neonates, we screen for breast cancer, we screen for bowel cancer. But you can't just screen for everything.
You absolutely cannot. The World Health Organization established a very strict set of criteria that a disease must meet before a government will fund and implement a population-wide screening program.
And most of it is common sense, right?
If you read through the list, the vast majority of the criteria are just pure, undeniable common sense.
Run us through the highlights of that WHO criteria list so we have the context.
Sure. The condition must be an important health problem. We aren't going to screen millions of people for minor ingrown toenails. There must be a recognizable early or latent stage of the disease. The natural history of the condition from latent to declared disease must be adequately understood.
Okay, that makes sense.
There must be a diagnostic test that is acceptable to the population and sufficiently accurate. There must be an accepted, effective treatment available, and the entire program must be economically sustainable and cost-effective.
When you lay it out like that, it sounds incredibly logical. So how does the exam turn this into a trap?
The exam will present you with a list of statements that sound like plausible WHO criteria and ask you to identify the false statement, the one that absolutely does not belong.
And what's their favorite trick?
Their absolute favorite recurring trick statement is this: the disease is one in which late treatment is as effective as early treatment.
Let's do a deep dive into the underlying philosophy of screening to explain exactly why that statement is false. Because on the surface, late treatment is just as good. Sounds vaguely reassuring. Why does that completely shatter the justification for a screening program?
To understand this, you have to look at the immense toll of screening. Screening an entire population of asymptomatic, healthy people is not a benign act.
No, it's not.
It requires millions of dollars in infrastructure. More importantly, it carries massive morbidity. Think about the psychological terror inflicted on thousands of people who receive false positive results. Think about the invasive biopsies, the radiation exposure, the unnecessary prophylactic surgeries.
Right. If you screen 100,000 women for breast cancer, you are inherently subjecting a percentage of healthy women to severe anxiety, biopsies, and potentially surgical complications for lesions that may never have harmed them.
Yeah.
The morbidity of the program itself is substantial.
Exactly. The only ethical, medical, and economic justification for inflicting that toll on a population is if catching the disease early radically changes the patient's ultimate outcome. Early treatment must be vastly superior to late treatment.
So, if a disease is totally curable with a simple pill, even if you find it in its late symptomatic stage, or conversely, if it's completely untreatable and fatal no matter when you find it, there is zero benefit to hunting for it early.
Precisely. If late treatment is just as good as early treatment, why on earth would we spend billions of dollars and cause massive societal anxiety trying to find it 5 years earlier? We would simply wait for the patient to present with natural symptoms, treat them then, and achieve the exact same successful outcome.
The core logic is that early intervention must offer a distinct survival or morbidity advantage for screening to make sense.
And therefore, the statement, late treatment is as effective as early treatment, completely undermines the fundamental foundational rationale of public health screening. It is always the wrong fit, false statement.
To consolidate that concept for the listener twice, screening only works, and is only ethical, if early treatment drastically beats late treatment. Therefore, if an exam option claims late treatment is as good as early treatment, that is the false criterion. It invalidates the need to screen. Late is as good as early is false. If you only remember one thing from topic 3, it's exactly that philosophical anchor. Screening demands an early advantage, so late treatment being equally effective is always the false WHO criterion. If you only remember one thing from topic 3, it's exactly that philosophical anchor. All right, we are going to take a breath here. We have reached our first mental checkpoint.
A good place for a pause.
Yeah. We are about to completely shift gears from evaluating data to applying physical science in the operating theater. But before we make that jump, let's lock in the foundational rules we just built. If you are behind the wheel, stay focused. I'm going to rapid-fire synthesize the core discriminators. Stats decision tree. 2 questions. Parametric or non-parametric? Paired or independent? 2 independent parametric groups means unpaired t-test. 2 independent non-parametric groups means Mann-Whitney U-test. It is not Kruskal-Wallis. Mann-Whitney U for 2 groups. Stats decision tree. 2 questions. Descriptive stats. In skewed data, the median is the most reliable anchor. Stats decision tree. 2 questions. Study design. In a true double-blind trial, the outcome assessor must be blinded to prevent observer bias. Stats decision tree. 2 questions. Plots. Forest plots summarize the big picture pool effect. Funnel plots detect publication bias by exposing missing negative studies. Stats decision tree. 2 questions. Screening. Early treatment must offer an advantage, so the statement late treatment is as good as early treatment is the false trap.
That foundation is rock solid. Now, we leave the spreadsheets behind and scrub into the operating theater. Topic 4, theater science, radiation safety, and the C-arm.
This is incredibly relevant for orthopedic surgeons. We live, breathe, and operate in front of fluoroscopy machines.
We really do.
The exam extensively tests your understanding of the variables that govern radiation dose, both to the patient and to the surgical team. What is the fundamental physics principle driving this?
Everything regarding radiation safety flows from basic beam physics in the inverse square law.
The inverse square law.
Yes. It dictates that the intensity of radiation is inversely proportional to the square of the distance from the source.
Let's translate that into practical terms for the surgeon holding a drill.
It means that distance is your absolute best friend. The drop-off in radiation intensity is exponential, not linear. If you take one step back and double your distance from the X-ray source, your radiation exposure doesn't just cut in half, it drops to 1/4. If you step back and triple your distance, your exposure drops to 1/9. The dose falls off a cliff the further away you get.
So maximizing distance minimizes dose. Now let's talk about the variables that inherently increase the exposure dose in the OR.
Exposure goes up significantly when you are imaging a larger, thicker body part. A lateral pelvis requires a vastly higher energy beam to penetrate the tissue than a finger.
Makes sense.
Exposure goes up when the body part is positioned closer to the X-ray source. It goes up when you use a large standard C-arm rather than a mini C-arm, and it goes up immensely when you do not collimate the beam.
Explain the physics of collimation quickly for those who just leave it to their radiographer.
Collimating means adjusting the lead shutters inside the C-arm to physically narrow the X-ray beam. Instead of radiating the entire limb in a wide circle, you restrict the beam so it only hits the exact tiny square of bone you were trying to visualize.
So less tissue irradiated means less overall dose and less scatter. So to decrease the dose, we do the exact opposites. Keep the patient as far from the source as possible, put the anatomy as close to the image intensifier, the receiver, as possible, and strictly collimate the beam. But there's a massive positional rule regarding the C-arm that confuses people. The two under the table rule. Unpack the physics of why that matters.
To understand this, you have to understand the Compton scatter effect. When high-energy X-rays leave the tube and hit dense human tissue, not all of them pass through to the receiver. Many of them hit the patient and deflect or bounce backward.
That is scatter radiation.
Yes, and scatter radiation is always most intense on the side of the patient closest to the X-ray source.
I use a visual analogy for this. Think of the X-ray source tube as a blindingly bright, incredibly hot lamp. You obviously want the patient as far from that hot bulb as possible, but what about the surgeon leaning over the table? If that hot bulb is positioned above the patient firing downward, the X-rays hit the patient and violently bounce backward as scatter. They bounce right up into the surgeon's face, neck, and hands.
Exactly. You are putting the surgical team directly in the primary scatter cloud.
But if we put the hot bulb, the X-ray tube, underneath the operating table, firing upward, the physics change entirely in our favor.
How so?
The primary backscatter now bounces downward toward the floor. It is absorbed by the dense operating table and aimed at the surgeon's lead-skirted shins, completely protecting the surgeon's hands, thyroid, and eyes from the worst of the scatter cloud.
That is the precise physics of it. Tube under the table directs the highest intensity scatter away from the vital organs of the operator.
Now, the exam is going to present you with a complex question regarding all these variables, distance, collimation, C-arm size, and ask you to identify the single most powerful lever you control to reduce radiation dose.
Right.
What is the ultimate rule?
The single most powerful direct lever the surgeon controls is screening time. It is a perfect linear relationship. If you have your screening time, you have the dose.
It's that simple.
A mini C-arm is great, collimation is essential, stepping back helps exponentially. But absolutely nothing beats simply communicating with your radiographer and taking your foot off the pedal.
To cement that critical discriminator for the listener twice, while distance and collimation are vital, the single biggest, most direct lever you have to reduce radiation exposure is reducing total screening time. Have the time, have the dose. Biggest lever is time. If you only remember one thing from Top It 4, it is this. Radiation dose rises with thicker anatomy, closeness to the X-ray source, large C-arms, and uncollimated beams. Tube under the table protects the surgeon from backscatter. But cutting your screening time is the ultimate, most powerful lever you control. Let's stay in the operating theater and move to topic 5. Diathermy, the movie. We use it in literally every single case, but the exam demands we understand the underlying physics.
There are two main axes of knowledge we need to define here. The first is the circuit path, monopolar versus bipolar diathermy. And the second is the energy delivery, cutting versus coagulation waveforms.
Let's start by defining the circuits. Explain the journey of the electrical current in monopolar diathermy.
In monopolar diathermy, the electrical current leaves the active tip of your handheld instrument, enters the patient's body, and then must travel a long distance all the way through their tissues to exit via a sticky return plate.
The grounding pad.
Yes, the grounding pad that is attached somewhere else on their body, usually a highly vascularized area like the thigh. The current traverses the patient.
And how does bipolar differ?
In bipolar diathermy, the instrument is designed like a pair of forceps. Both the active electrode and the return electrode are built right into the two opposing tips of the forceps.
Oh, I see.
So when you step on the pedal, the electrical current only travels across the tiny 1 millimeter gap of tissue physically pinched between the forceps. It does not flow through the rest of the patient's body to find a grounding pad.
Which brings up a massive, highly tested clinical safety application regarding cardiac pacemakers.
Exactly. Because bipolar diathermy keeps the electrical current strictly confined between the instrument tips, it is vastly safer to use around patients with implanted pacemakers or defibrillators.
Because the current doesn't travel.
Right. In monopolar, you are sending a rogue, high-frequency electrical current traversing across the patient's torso, which can easily confuse the pacemaker, cause it to misinterpret the signal as an arrhythmia, or short it out entirely.
So to lock that clinical application in twice, bipolar diathermy keeps the current confined between the forceps tips, meaning it does not traverse the body, making it vastly safer for patients with pacemakers. Bipolar is safer for pacemakers. Now for the second axis. This requires precise memorization of the physics of the waveforms, cutting versus coagulation.
When you want to cleanly cut tissue, the machine uses a continuous, uninterrupted alternating current with a sine waveform.
A fine wave.
Yes, it is constantly delivering power. This continuous high energy instantly heats the intracellular water to boiling point, causing the cells to literally vaporize and explode, which cleanly separates the tissue. That is cutting.
So, cutting equals a continuous current with a sine waveform, resulting in vaporization.
Conversely, when you want to coagulate tissue, to seal a bleeding vessel without slicing through it, the machine uses a pulsed, interrupted current with a square waveform.
A square waveform.
Right. The current is rapidly turning on and off. This results in a lower average energy delivery. Instead of instantly vaporizing the water, it slowly heats the tissue, denaturing the cellular proteins and forming a solid coagulum.
This discriminator is heavily tested, so let me synthesize it clearly twice. Cutting tissue requires a continuous current with a sine waveform. Coagulating tissue requires a pulsed, interrupted current with a square waveform. Cutting is continuous sine, coagulating is pulse square.
Perfect. Now, before we leave diathermy, we must address a very common myth that is tested on the exam.
What's the myth?
What happens if you are dissecting with monopolar diathermy and you accidentally touch a large metal orthopedic implant inside the patient, like a femoral nail or a massive titanium plate? The instinctive fear is that the metal instantly heats up and causes thermal necrosis of the surrounding bone.
Yeah, it's a terrifying thought. You touch a conductive metal plate with a live movie, and you assume you've just deep-fried the femur. Does the bone cook?
No, it does not. And the exam wants you to understand the exact physics of why it doesn't. It all comes down to Ohm's law, Joule heating, and specifically current density based on surface area.
Unpack current density for us.
The tip of your diathermy blade is incredibly sharp and tiny. It has a minuscule surface area. So when the current flows out of that tiny tip, the electrical energy is highly concentrated. That is high current density, and that intense concentration is exactly why it generates enough focal heat to instantly burn tissue.
Okay.
But an orthopedic plate or an intramedullary rod has a massive, huge surface area compared to that tiny blade.
So what happens to the energy when the movie touches the plate?
The moment the current hits the metal plate, it instantly dissipates and spreads out evenly across the entire massive surface area of the implant. Because the area is so large, the current density drops to almost nothing.
The physical analogy here is pressure. It's the exact difference between stepping on someone's foot with a sharp stiletto heel versus stepping on them while wearing a giant, wide snowshoe.
That's a great way to look at it.
The snowshoe spreads the exact same amount of force over such a large area that it is completely harmless. Same force, completely different pressure.
That is precisely it. Because the implant has such a massive surface area, brief incidental contact with the diathermy completely diffuses the energy. The current density plummets, and it simply does not generate enough focal heat to cause thermal necrosis of the bone.
That is brilliant physics applied to surgery. Let's cement that concept twice. Touching a metal implant with diathermy does not cook the bone because the implant has a massive surface area, which diffuses the energy and results in a harmlessly low current density. Massive surface area keeps current density low. If you only remember one thing from topic 5, it is this. Cutting is a continuous sine wave. Coagulation is a pulsed square wave. Bipolar is safer around pacemakers because current doesn't cross the body. And massive surface area protects implants by keeping current density low. Let's keep the theater science rolling into topic 6. Tourniquets. We use them in almost every extremity case to achieve a bloodless field, but they are not benign. There is inherent morbidity. Specifically, the exam zeroes in on tourniquet-induced nerve injuries.
The exam wants to know the exact physiological mechanism of that nerve injury. And this is where a lot of candidates stumble because they rely on intuition rather than the science.
Right, instinctually you think. I've inflated a cuff. I've stopped all the arterial blood flow to the limb so the nerve is starving for oxygen. It must be ischemic damage.
It is a perfectly reasonable guess, but it is unequivocally wrong for the exam.
Wow. Okay.
The primary mechanism of tourniquet nerve injury is direct, mechanical compression under the edges of the cuff, not distal ischemia. The physical pressure of the inflated bladder literally crushes the myelin sheath and disrupts the cytoskeleton of the axons, particularly at the nodes of Ranvier.
Let me lock that in because it's a massive trap. Tourniquet nerve injury is driven by direct mechanical pressure crushing the myelin, not by a lack of blood flow or ischemia. Say it again. Tourniquet injury is pressure, not ischemia.
And understanding that it is fundamentally a pressure problem entirely dictates our safety guidelines. Let's go back to basic physics. Pressure equals force divided by area.
Okay.
So if we need to apply enough force to stop arterial blood flow, but we want to minimize the pressure on the underlying nerve, what kind of tourniquet cuff must we use?
They have to maximize the area, so wider cuff.
Exactly. A wider cuff is inherently safer because it spreads the necessary compressive force over a much larger surface area of the limb.
I use the backpack analogy here. If you carry a heavy backpack with thin, narrow strings for straps, all that force is concentrated on a tiny line, and it cuts deeply into your shoulders. If you use wide, heavily padded straps, it spreads the exact same load over a huge area, and it's comfortable. Same force, completely different pressure.
Precisely. Because the injury mechanism is pressure, a wider tourniquet cuff is safer. Now, let's hit the specific numerical guidelines the exam loves to test. What should the actual inflation pressure be set at?
The universally accepted safe guideline is roughly 100 millimeters of mercury above the patient's systolic blood pressure. So in practical routine adult orthopedics, if a patient's systolic is 120, that usually translates to setting an arm tourniquet around 200 or 250 and a bulky thigh tourniquet around 250 to 300, depending on the tissue envelope.
To consolidate the core rule, the safe tourniquet inflation pressure is set approximately 100 millimeters of mercury above the patient's systolic pressure.
100 above systolic. There's one more numerical fact you need to bank regarding the nerve damage we discussed. If you routinely perform nerve conduction studies, EMG tests on patients a few days after standard tourniquet use, what percentage of them will actually show measurable electrical abnormalities?
It is a surprisingly high number. EMG abnormalities occur in over 70% of patients.
Over 70%.
Yes. Now, we must clarify that these are almost entirely transient subclinical neuropraxias. The patient doesn't complain of weakness and it resolves on its own. But if you look at the raw electrical data, the conduction delay is undeniably present in over 70% of cases.
Over 70% show EMG changes.
Yeah.
That's a hard statistic to memorize, but you need it. Now bring us a specific exam trap for tourniquets. There's a statement floating around in the quizzes that candidates constantly get tangled on regarding single versus double cuffs.
The exam loves to present a list of statements about tourniquets and ask you to identify the false one. The false statement, the trap, is this: single cuffs are better than double cuffs.
Explain why it is false to claim a single cuff is universally better.
Because it compares apples to oranges. There is absolutely no evidence that a single cuff is inherently better or safer than a double cuff for routine orthopedic hemostasis. A double bladder cuff is a highly specific tool used primarily by anesthetists for intravenous regional anesthesia.
Like a Beer's block.
Exactly, a Beer's block.
Right. In a Beer's block, you inflate the proximal cuff, inject the local anesthetic into the vein, and let it set. But after 30 minutes, that proximal cuff starts causing severe ischemic pain. So you inflate the distal cuff over the area that is now fully numb and then deflate the proximal cuff. It prevents tourniquet pain while keeping the anesthetic trapped in the limb.
Exactly. It is a specialized technique for anesthesia, not a superiority contest for stopping bleeding. So claiming that single cuffs are universally better than double cuffs is a false statement.
To cement that trap twice. A double cuff serves a specific purpose in regional anesthesia. Therefore, the blanket statement that single cuffs are better than double cuffs is false. Single cuffs are not inherently better than double cuffs. If you only remember one thing from topic 6, it is this. Tourniquet nerve injury is driven by direct mechanical pressure, not ischemia, which is exactly why a wider cuff is safer. Set the pressure roughly 100 above systolic and expect transient EMG abnormalities in over 70% of patients. If you only remember one thing from topic 6, it is this. We have hit mid-episode recap 2, another mental checkpoint. We're about to dive into the deep clinical science one-offs. If you are commuting, grip the wheel. Let's rapid-fire consolidate theater science. If you only remember one thing from topic 6, it is this. Radiation safety. Distance is your best friend. Dose goes up with a thicker body part, closer X-ray source, large C-arm, and longer time. The tube goes under the table to direct backscatter away from the surgeon, and the single most powerful direct lever you control is screening time. Have the time, have the dose. Diathermy. Bipolar is safer for pacemakers because the current stays strictly between the instrument tips. Waveforms. Cutting requires a continuous sine wave to vaporize tissue. Coagulation requires a pulsed square wave to denature tissue. Touching a metal implant is safe because its massive surface area diffuses the energy, keeping current density harmlessly low. Diathermy. Bipolar is safer for pacemakers because the current stays strictly between the instrument tips. Waveforms. Tourniquets. The mechanism of nerve injury is direct mechanical pressure, not ischemia, so a wider cuff is inherently safer. Set the pressure roughly 100 above systolic. Subclinical TMG changes occur in over 70% of patients, and the statement single cuffs are better than double is false.
Outstanding consolidation. The foundation is locked. Now we enter topic 7, clinical science one-offs. These are high-yield, standalone clinical scenarios pulled directly from the source material.
They don't really fit neatly into a single thematic category.
No, but they are tested relentlessly, and we need to unpack the why behind each of them.
Let's do exactly that. We'll
Okay.
take them one by one. I want to start with an absolute nightmare scenario in trauma surgery. A polytrauma patient comes into the emergency department following a high-speed motor vehicle collision. They have massive tissue crush injuries.
Okay.
Paradoxically, they are simultaneously throwing microvascular blood clots in their extremities. Their digits are turning ischemic, while their surgical incisions and IV sites simply will not stop oozing and bleeding.
You are describing the classic catastrophic presentation of disseminated intravascular coagulation, or DIC. The exam demands, the specific molecular trigger that initiates this entire chaotic cascade.
Unpack the mechanism. What is the trigger?
The entire cascade is driven by the massive widespread release of a molecule called tissue factor, which is historically also known as thromboplastin.
Tissue factor.
Yes, tissue factor is normally hidden away inside the subendothelial tissue, out of contact with the blood. But when massive, catastrophic physical trauma occurs, millions of cells are crushed and massive amounts of tissue factor flood into the systemic bloodstream.
And what does that systemic flood of tissue factor do?
It inappropriately and simultaneously activates the extrinsic coagulation cascade everywhere in the body at once. That explains the clotting phase. The patient forms thousands of microscopic thrombi in their microvasculature, leading to organ ischemia.
Okay, so the tissue factor explains why they are clotting everywhere. But why are they simultaneously bleeding to death from their 5E sites?
Because DIC is fundamentally a consumption coagulopathy. By forming those thousands of microscopic clots all over the body, the systemic cascade rapidly consumes and completely depletes all of the patient's circulating clotting factors, fibrinogen, and platelets.
The tank is completely empty.
There is nothing left. So simultaneously, the patient loses the ability to form a normal clot anywhere, and they begin to hemorrhage from every wound.
That is a phenomenal explanation.
Yeah.
To cement that mechanism twice. DIC is a consumption coagulopathy driven by the massive release of tissue factor, also called thromboplastin, which activates widespread clotting, completely depletes the coagulation factors, and results in paradoxical hemorrhage. DIC is triggered by tissue factor.
Now, hold on to that exact same molecule because it bridges perfectly to our next topic, deep vein thrombosis, or DVT.
Okay.
The exam will ask you to identify the specific physiological trigger that initiates the coagulation cascade during normal, routine surgical dissection, putting orthopedic patients at such high risk for DVT.
Let me guess. It's the exact same trigger.
It is the exact same molecule, tissue factor. Every time you use a scalpel or diathermy to cut through healthy tissue, you are causing localized cellular trauma. That localized trauma exposes and releases tissue factor into the venous system. That tissue factor activates the extrinsic clotting pathway, promoting thrombus formation. That is the fundamental reason why the act of surgery inherently raises the risk of DVT.
To link those two concepts twice, whether it is massive polytrauma causing DIC or localized surgical dissection increasing DVT risk, the activating molecule is tissue factor kicking off the extrinsic pathway. Tissue factor triggers both DIC and DVT risk. Let's move on to sepsis. The clinical definitions of sepsis have evolved significantly over the last decade, but the FRCS exam still rigidly tests specific physiological thresholds. Let's build it from the ground up, starting with SIRS, systemic inflammatory response syndrome.
SIRS is a clinical threshold indicating widespread inflammation. To meet the criteria for SIRS, a patient needs 2 or more of the following abnormal vital signs.
What are they?
An abnormal core temperature, either a high fever or severe hypothermia, a tachycardic heart rate over 90 beats per minute, an elevated respiratory rate, or a deranged white blood cell count, which can be either severely elevated or heavily depressed. If you have 2 of those derangements, you have SIRS.
Okay, that's SIRS. What upgrades that diagnosis from SIRS to sepsis?
Sepsis is simply defined as meeting the criteria for SIRS plus having a confirmed or highly suspected source of infection.
And what upgrades sepsis to severe sepsis?
Yes.
Because this is where the specific exam trap lies.
Severe sepsis is defined by the onset of organ dysfunction, tissue hypoperfusion, or severe hypotension. And the specific prognostic blood marker they test to identify cellular hypoperfusion is serum lactate.
Serum lactate.
The threshold for defining severe sepsis is a serum lactate level strictly over 2 millimoles per liter.
Let's explain the biology of why lactate rises, because it really grounds the concept.
It comes down to cellular metabolism. When the organs are underperfused, meaning they aren't getting enough oxygenated blood, the cells cannot maintain aerobic metabolism. To survive, they are forced to switch to anaerobic glycolysis.
And the byproduct of that is?
The primary toxic byproduct of anaerobic metabolism is lactic acid. Therefore, a rising serum lactate is a direct, measurable alarm bell that the patient's tissues are suffocating and starving.
And what is the specific exam trap regarding the number?
Well, the source quizzes often include a distractor statement claiming that a lactate under 2 indicates severe sepsis. That is entirely false. A normal lactate is under 2. For it to indicate severe sepsis, the lactate must be over R.
Consolidating the threshold twice. Severe sepsis is defined by tissue hypoperfusion, driven by anaerobic metabolism, and marked by a serum lactate strictly over 2. Severe sepsis requires a lactate over 2. Next, one off topic. Tranexamic acid, or TXA. In modern orthopedics, particularly in total joint arthroplasty, we use this constantly.
We do. TXA is an antifibrinolytic medication. Its mechanism of action is that it competitively inhibits the activation of plasminogen to plasmin.
What does plasmin do?
Plasmin is the enzyme responsible for breaking down fibrin clots. So, by inhibiting plasmin, TXA stops the breakdown of clots. It stabilizes the clots that the body naturally forms at the surgical site, so the patient stops the bleeding.
And clinically, it is incredibly effective. It significantly reduces the need for postoperative blood transfusions. But there is a massive logical paradox here that worries patients and trainees alike.
Which is?
If TXA chemically stops clots from breaking down, doesn't it massively increase the risk of the patient suffering a deep vein thrombosis or a pulmonary embolism?
Logically, you would absolutely assume it does. It seems intuitive that an anti-bleeding drug would cause systemic clotting. But what does the highest level evidence actually say?
The evidence says no.
Exactly. Massive, multi-center, randomized controlled trials and meta-analyses have definitively shown that, crucially, TXA does not increase the overall risk of DVT or PE in joint replacement patients.
I want to clarify the why on that briefly. It's because TXA doesn't magically generate new thrombin or create new clots out of nowhere. It simply stabilizes the clots that the body's local trauma response has already formed. It prevents premature lysis at the wound site, but it doesn't cause systemic hypercoagulability.
That is a perfect physiological summary.
So to cement the tested fact twice, tranexamic acid is an antifibrinolytic that heavily reduces transfusion needs, but crucially, it does not increase the risk of DVT or PE. TXA does not cause DVTs. Next topic, sickle cell disease and bone infections. This is a classic board question across every surgical specialty.
Patients with sickle cell disease are highly disproportionately prone to developing osteomyelitis infections of the bone. But there is a specific, unusual bacterial organism you must immediately associate with them for the exam.
Walk us through the microbiology.
In the general healthy public, the vast majority of osteomyelitis is caused by Staphylococcus aureus. And while staph is still common in sickle cell patients, these patients have a unique, profound vulnerability to osteomyelitis caused by Salmonella.
We need to explain the physiological why behind that connection. Why Salmonella? It's an enteric gut bacteria. How does it end up destroying the femur of a sickle cell patient?
It is a perfect storm of pathology. First, the sickled red blood cells cause sluggish, sludgy blood flow in the medullary cavity of the bone, leading to microscopic areas of infarction and dead bone. That dead tissue is a perfect avascular nidus for bacteria to land and hide.
That's the first hit.
Second, these patients suffer from microvascular infarcts in their bowel wall, which allows normal gut flora like Salmonella to translocate across the gut wall and enter the bloodstream.
And normally the spleen would filter that out.
Exactly. But patients with severe sickle cell disease typically suffer from autosplenectomy by adulthood.
Meaning their spleen has infarcted and shriveled up.
Right, destroying their ability to effectively clear encapsulated organisms and certain bacteria like Salmonella from their blood. So the gut bacteria enters the blood, the spleen fails to clear it, and it finds a perfect home in the infarcted bone marrow.
That is exactly the depth we need. So to consolidate the classic association twice, due to autosplenectomy and bone marrow infarcts, patients with sickle cell disease are uniquely prone to osteomyelitis caused by Salmonella. Sickle cell bone infection equals Salmonella. Final clinical one-off for this section, fluoroquinolone antibiotics, specifically the drug ciprofloxacin. We use it occasionally for complex infections, but what is the catastrophic orthopedic complication associated with it?
Fluoroquinolones are highly toxic to tenocytes, the cells that maintain tendons. Taking ciprofloxacin can cause severe tendinopathy, and classically, it leads to the spontaneous atraumatic rupture of the Achilles tendon.
That's brutal.
Incredibly, roughly half of these cases are bilateral. Both Achilles tendons snap simultaneously while the patient is simply walking.
Unpack the cellular mechanism briefly. Why does it destroy the tendon?
Ciprofloxacin upregulates enzymes called matrix metalloproteinases, or MMPs. These enzymes aggressively degrade collagen. At the same time, the drug inhibits the proliferation of new tenocytes and decreases collagen synthesis.
So you have aggressive degradation combined with halted repair.
The tendon structurally fails.
And who is the classic high-risk patient demographic for this complication?
The exam wants you to identify the specific risk factors. The risk of Achilles rupture on Cipro skyrockets in patients over the age of 60, patients with diabetes, patients with renal impairment, and crucially, patients who are concurrently taking systemic corticosteroids.
So an elderly diabetic patient on prednisone who is given Cipro for a UTI is at massive risk for snapping their Achilles. To cement the rule twice. Fluoroquinolones, like ciprofloxacin, cause Achilles tendon rupture by degrading collagen, especially in patients over 60 taking corticosteroids. Cipro ruptures the Achilles. If you only remember one thing from topic 7, it is this. DIC is a consumption coagulopathy triggered by tissue factor. Severe sepsis demands a lactate strictly over 2. TXA stops bleeding without raising DVT risk. Sickle cell osteomyelitis is intrinsically linked to Salmonella. And ciprofloxacin severely degrades collagen, rupturing the Achilles tendon. All right, we are nearing the finish line. We have reached topic 8, antibiotic mechanisms and the gait cycle.
We need to be incredibly careful here. Similar to the stats decision tree, the primary source material, the practice quizzes that many candidates use to study these basic sciences, contains direct, factual, biological errors regarding how these antibiotics function.
Yes, it does.
We must correct them on air right now so you do not carry bad data into the exam hall.
Let's fix the errors and build the correct exam-ready facts. We will go drug by drug, focusing on their exact mechanism of action. Let's start with the one we just discussed, ciprofloxacin. How does it actually kill bacteria?
Ciprofloxacin and all the fluoroquinolones exert their bactericidal effect by inhibiting a bacterial enzyme called DNA gyrase, which is a type of topoisomerase II.
What does DNA gyrase do?
When bacteria want to replicate, they have to unzip their tightly coiled double helix of DNA. But unzipping it causes extreme tension and supercoiling further down the strand. DNA gyrase acts like a swivel. It cuts the DNA, relaxes the tension, and reattaches it.
And Cipro stops that.
Ciprofloxacin blocks that swivel. The tension builds, the DNA strand shatters, and the bacteria cannot replicate.
Ciprofloxacin inhibits DNA gyrase, stopping replication. Got it.
What about vancomycin? This is our heavy hitter for MRSA.
Vancomycin is a glycopeptide, and it works by inhibiting bacterial cell wall synthesis. The exam trick here is specificity. It stops the cross-linking of the peptidoglycan wall by binding very tightly to the diella-diella terminus of the cell wall precursors. Diella-diella.
Crucially, do not let the exam confuse you by swapping the words cell wall for cell membrane. Human cells have membranes, bacteria have rigid walls. Vancomycin attacks the bacterial cell wall.
Vancomycin inhibits cell wall synthesis by binding diella-diella. Okay, now for the major errors in the quiz. Let's look at rifampicin.
Rifampicin is a critical antibiotic, especially in mycobacterial infections and biofilm eradication in paraprosthetic joint infections. It works by inhibiting bacterial RNA polymerase.
RNA polymerase.
However, the source quiz incorrectly states that it inhibits DNA polymerase. That is biologically and factually wrong. It targets RNA polymerase to block the transcription of RNA from DNA.
I'm going to consolidate that correction firmly twice so it overwrites any bad data. Rifampicin works by inhibiting RNA polymerase, not DNA polymerase. Rifampicin equals RNA polymerase.
Now for error number 2 in the quiz material. This one concerns the massive class of drugs that target the bacterial ribosome to stop protein synthesis. Bacterial ribosomes are made of 2 distinct chunks, a smaller 30S subunit and a larger 50S subunit.
Walk us through the true targets.
The macrolide class of antibiotics, which includes erythromycin and clarithromycin, bind to the larger 50S subunit. The source quiz contains a statement claiming erythromycin binds the 30S subunit.
Which is false.
That is the incorrect statement, and the exam wants you to identify it as false. Macrolides are strictly 50S. On the other hand, the aminoglycoside class, which includes gentamicin, bind to the smaller 30S subunit.
There are dozens of medical school mnemonics for this, but the simplest way to cement the correction is just direct synthesis. Macrolides, like erythromycin, attack the 50S subunit. Aminoglycosides, like gentamicin, attack the 30S subunit. And rifampicin hits RNA polymerase.
Excellent. We have one final pure biomechanics one-off to cover before we hit the lightning round finale. We need to talk about the mechanics of the gait cycle.
Specifically, the exam hones in on ankle motion during the various phases of the gait cycle. What is the highly tested discriminator here?
The exam wants to know at what exact point in the gait cycle the foot reaches its point of maximum dorsiflexion. Dorsiflexion meaning the foot is flexed upward, pulling the toes toward the shin as far as the joint will physically allow.
And what is the correct phase?
Maximum dorsiflexion occurs during mid-stance.
We have to unpack the biomechanical why here, because this is deeply counterintuitive to most people. If you ask someone to guess, they usually assume maximum dorsiflexion happens during the swing phase.
Right, when the leg is in the air and the tibialis anterior muscle is actively firing to flex the foot up so the toes don't drag on the ground.
That seems logical.
That is a logical assumption because that is active muscular dorsiflexion. But it is not the maximum geometric angle the joint achieves. Maximum dorsiflexion is actually a purely passive weight-bearing event.
Walk us through the mechanics of mid-stance.
Imagine taking a step. During mid-stance, your foot is planted completely flat on the ground, bearing your entire body weight. As your body's center of mass continues to move forward, your tibia, your shin bone, has to pivot and tilt aggressively forward over that planted stationary foot.
The foot is glued to the floor, but the entire weight of the body is driving the shin bone forward over it.
Exactly. That massive forward momentum of the body creates an acute, deeply compressed angle at the front of the ankle joint. The body's weight passively forces the ankle into absolute maximum dorsiflexion just a split second before the heel finally lifts off the ground for the push-off phase.
That is a brilliant mechanical visualization. To consolidate the rule twice, the ankle joint is forced into its maximum passive dorsiflexion angle during mid-stance as the tibia rolls forward over the planted foot. Maximum dorsiflexion is at mid-stance. If you only remember one thing from topic 8, it is the corrections. Rifampicin hits RNA polymerase, macrolides like erythromycin hit the 50S subunit, and maximum passive ankle dorsiflexion occurs at mid-stance.
And that, impressively, brings us to the finale.
Yes, it does. You have made it to the final lightning round. We are going to drill the absolute most critical, frequently tested discriminators from this entire deep dive session. I'm going to rapid fire the clinical setup, and I want you to answer instantly. If you are listening in your car or at the gym, I want you to actively shout the answer out loud before the expert says it. Active recall is how you win. Here we go. Comparing 2 independent parametric groups.
Unpaired teats.
Comparing 2 independent non-parametric groups.
Man-Whitney U-test.
The most frequent value in a skewed dataset.
The mode?
Forest plot versus funnel plot.
Forest summarizes pooled effect, funnel detects publication bias.
The universally false WHO screening criterion.
That late treatment is as good as early.
The single biggest lever you control to cut radiation dose.
Screening time.
Cutting versus coagulation diathermy waveform.
The cutting is continuous sine, coagulation is pulsed square.
Why touching an implant with diathermy doesn't cook bone?
Massive surface area diffuses current density.
The safer tourniquet cuff.
Wider, Because the injury is caused by direct pressure, not ischemia.
Severe sepsis lactate threshold.
Strictly over 2.
Sickle cell osteomyelitis organism.
Salmonella.
Rifampicin and erythromycin cellular targets.
Rifampicin targets RNA polymerase. Erythromycin targets the 50S ribosomal subunit.
Boom. Absolutely nailed it.
I want to leave the listener with a final, slightly provocative thought on all of this material. When you first open the basic science syllabus, the overwhelming instinct is to resort to brute force rote memorization. Flashcards, highlighting, cramming disparate facts into your short-term memory. But if you've listened to how we unpack the mechanisms today, you realize you don't actually have to rely on a fragile memory.
Unpack that philosophy for us.
If you truly understand the underlying physics, like the inverse square law of radiation, or how massive surface area diffuses electrical current density, or how pressure distributes under a wide cuff, the answers derive themselves logically. If you understand the deep ethical and economic why behind screening a healthy population, you don't have to memorize a bulleted list of WHO criteria.
You just spot the flaw.
You can just instantly spot the one statement that logically breaks the entire system.
Because the why is the anchor.
Exactly. You don't have to rely on rote memory when you understand the foundational why beneath the facts. The science proves the rules.
That is an incredibly powerful way to approach revision. Well, we have reached the end of the line. Congratulations on putting in the time to claim the free marks of the Basic Science finale. We highly encourage you to let this audio loop again on your drive tomorrow. Let the repetition and the synthesis sink in on the second and third pass.
It absolutely will sink in. You have done the heavy lifting today.
Best of luck on the FRCS exam. You have entirely got this. And remember what we said at the very start. It might feel like you're staring into muddy, abstract waters right now, but once you understand the physics, the biology, and the logic, that diagnostic X-ray of the exam clears right up, and the correct answers are as clean and obvious as a jagged white line on a femur. Keep pushing. We'll see you next time.